inferior vestibular nuclei. Okay, we're gonna talk about those guys later on. Okay. Okay, so here we have the vestibular nuclei. This is a very nice diagram, you guys. I liked it because it shows you how the vestibular nuclei. Can you guys see that this is actually the floor of the fourth ventricle? We have the open medulla at that level, and then we have the pons. And remember when I told you that the vestibular nerve is related to the pons because it has most of the vestibular nuclei. It has the superior, it has the lateral, it has half of the medial. I drew this diagram to help you grasp the idea of the vestibular nuclei. So we have superior, inferior, medial, and lateral. Okay, vestibular nuclei. The information when it comes from the vestibular system, from your inner ear, related to the balance, you're gonna get the information all the way, and they need to relay in the vestibular nuclei, guys. And then we will have connections to control everything in our body, and this is what we call the medial longitudinal fasciculus, and we're gonna explain that later on, not now. But now, the vestibular nuclei, we have superior, inferior, medial, and lateral. The inferior and half of the medial are in the medulla, and we've seen that at the butterfly level. All right, it was here, lateral. Remember the hypoglossal and vagal trigon? It was lateral here. Exactly, this is the triangle that I made. Okay, this is a triangle. This is the vestibular area. Okay, guys, this is here. So, superior here, superior, lateral, and half of the medial is in the pons. This is pons, guys. And half of the medial and inferior vestibular nuclei are related to the medulla. Okay, so this is just, I want you to grasp the idea of the vestibular nuclei. Okay, now let's talk about the cranial nerves. Now we've seen the internal structure of the medulla. Now we know everything happening, but we just need to add some information about the function so that when we get to the blood supply and we see the injuries, we will understand what kind of signs and symptoms we are expected to see, right? Now, remember what was the cranial nerves, guys, related to the medulla? Can someone say it? I cannot hear you, but I can say it so you can hear me. 3 and 4 midbrain, 5, 6, 7, and 8 pons, 9, 10, 11, 12 medulla. So the 9 is the glossopharyngeal nerve. What's the name of that nerve? It's the glossopharyngeal nerve. Why is it called glossopharyngeal? Because it's related to the tongue and the pharynx. What does it do? It has 3 important nuclei that are related to the glossopharyngeal name. And there is also one nucleus that is giving information or innervation to the parotid gland. And guys, we're gonna talk about that in the digestive system. So don't worry much about how the glossopharyngeal is supplying the parotid by parasympathetic innervation. This is one of the 4 parasympathetic ganglia of head and neck, and I'm planning to make a video for that, so don't worry about that. I just want you guys to remember that we have the dorsal vagal nucleus, we have the nucleus ambiguous, and we have the nucleus of tractus solitarius. They are very important because they are in the medulla, and if we have a lesion, we need to know what's gonna happen. Okay, so yes, I have the same name of nuclei, but for the glossopharyngeal and vagus, they are not always the same. For example, the solitary nucleus or nucleus solitarius, it is related to the taste sensation. How did I remember that when I was a student? Taste, it has S and T. So S and T, the solitary nucleus, is for taste sensation from the posterior 1/3 of the tongue. Okay, then what about, this is the guys, the posterior 1/3 of the tongue. What about the anterior 2/3? You guys are going to take that later on. It's supplied by the facial nerve. Okay, so don't worry about the anterior 2/3. Okay, so the nucleus solitarius, it's related to the vagus and glossopharyngeal, and they are supplying the posterior 1/3. What else? When you guys remember vagus and glossopharyngeal, just remember the pharynx and larynx and stuff in the throat, the palate, and the things that we cannot see. And of course, everyone knows that the vagus supplies the heart and lung, you know, parasympathetic innervation, to slow down the heart rates, you know, to control based on your activity level, all right? So Remember that this is done by the dorsal vagal nuclei, all right? So the dorsal vagal nucleus, it's gonna be for the parasympathetic innervation that we talked about and the sensation of the pharynx and the soft palate, okay? Now, what about nucleus ambiguous? You guys, ambiguous is a motor nucleus. Motor nucleus. My two biggest fears when I was studying those things is that I hate the solitary nucleus and ambiguous because they are very strange names. So remember, the solitary, it has S and T for taste, and the ambiguous, it has M for motor. So this is gonna be for muscles. Okay, so what would be the muscles? Two very important group of muscles, you guys. Without that, I wouldn't have been able to talk right now. So the motor innervation of the laryngeal muscles is coming from here, from the larynx, okay, and also muscles of the pharynx. I wouldn't have been able to swallow now. And so the nucleus ambiguous is a motor nucleus. Ambiguous solitary nucleus, ambiguous solitary nucleus, solitary taste, ambiguous motor, okay? So the ambiguous in the vagus, it supplies the stylopharyngeus muscle. No, glossopharyngeal is stylopharyngeus. It's the opposite, guys. I'm sorry about that. The stylopharyngeus supplied by glossopharyngeal nerve, and the palate, pharynx, and larynx by vagus. Okay, so just consider that this is here and this is there. Okay, okay, so the glossopharyngeal nerve, I have a very nice video on how to memorize this in the digestive module playlist. You can go ahead and see it. Okay, so the glossopharyngeal nerve supplies the stylopharyngeus. So the nucleus ambiguous is motor for stylopharyngeus. Okay, here. However, these are the muscles, yes, supplied by nucleus ambiguous, but of vagus nerve. Okay, so without that, I wouldn't have been able to talk now. The laryngeal muscles supplied by vagus, and this is by nucleus ambiguous. Again, so mucus ambiguous, tractus solitarius, dorsal vagal nucleus. Okay, these are the three nuclei. We have them in vagus and glossopharyngeal. They are very important. And there is an important also test that you can do to the patient when you thrust the throat of the patient. You can stimulate the dorsal vagal nucleus, and that will have a reflex in the medullary level, and that will cause the patient to gag by activating the ambiguous. So remember that reflexes, guys, it's all about you are trying to test if there is a lesion at that level or no. So if you do a back thrust in a patient after, let's say, an accident or something, and you want to know if there is a lesion at the medullary level, you will do a back thrust to the throat of that patient. You will get an afferent limb going to, and that will give to the nucleus ambiguous, and that will give you an efferent limb that will cause the patient to gag. So the one was sensory and the other one is motor, and at the level of the medulla you will come to know if this patient is having an injury on medulla or no. All right, this is just an extra clinical information that will help you to grasp the idea of the nuclei of these two cranial nerves. Okay, we're going one by one. We talked about the glossopharyngeal, 9, and we talked about the vagus. Let's go to 11 and 12. Why did I put 11 in gray color? Because 11, the accessory, we had the cranial accessory and we have the spinal accessory. Cranial accessory nerve, you guys, they used to say it's a separate nerve and it has its nuclei, and now they are saying it's part of the vagus. So no one gives it any attention now. And even the spinal one, it comes from C1 to C6 spinal cord level. So the nuclei are not in the medulla. It's only they are forming down as C1 to C6, and then they ascend to the medulla. So I can see them here at the medullary level, the accessory, spinal accessory, and they are there. And if there is a problem, there will be a problem to them. But the cell bodies of these nerves, they are getting their information from the spinal cord levels, okay? And you guys know that the accessory is the motor nerve for sternocleidomastoid and trapezius, and that helps you to turn your head, all right? Now, the last cranial nerve related to the medulla is the hypoglossal nerve, and you guys know that the hypoglossal is a motor nerve for the muscles of the tongue. It supplies all muscles of the tongue except the palaroglossus. Palaroglossus is supplied by vagus. This is very nicely explained in the videos of the digestive module. I cannot explain them now, but for now you need to know that the hypoglossal nerve supplies all the muscles except the palaroglossus. And if you have a hypoglossal nerve injury, you need to know in that the tongue will deviate to the level of the legioned nerve, or the legioned muscle. Okay, so you can remember that this as lick your wound. So if I have a problem to the left side, my tongue will deviate to the left side. Why, guys? Because you guys, the muscles of the tongue, and it's nicely explained also in the videos of the digestive module, they can work together, except for the genioglossus. The genioglossus is the muscle. I would actually advise you guys to go ahead and watch that video. It's really nicely explaining how the tongue muscles work. Anyway, we have, here is the mandible, okay? So this is the mandible. The mandible has a genial tubercle. The genial tubercle gives the attachment of the genioglossus. This is your tongue, okay? So this is your tongue. And because this is anterior bone, so contraction of this brings your tongue outside, protrusion of the tongue. Okay, so this is a side view. Okay, guys, this is a side view. Now let's think about this view as this is your tongue. The genioglossus, the right one pushes outside and the left one pushes outside. If I have a problem, I just want you to grasp the idea of the legion. If I have a problem with this genioglossus, what do you think will happen? The other genioglossus is going to override. It's gonna push, and this is gonna be weak. So what will happen is the tongue is going to deviate to the affected side. That's why we say lick your wound. So you guys, this is a general rule for hypoglossal nerve. Whenever you have, even if it's upper motor neuron lesion or lower motor neuron lesion, the tongue is going to deviate towards the affected muscle because the affected muscle is not working. So the other muscle is pushing the tongue to that side. So lick your wound applies for both lesions. But, what is but? In the exam, you guys need to be aware. What are they asking about? The deviation of the tongue in relation to what? To the muscle itself, or to the nerve, or to the site of the lesion? If they mean the site of the lesion, the story is going to be different, and we're going to say now. How? Now. You guys, in the upper motor neurons, you guys know that upper motor neurons means what? If I have a cortex, and those neurons are the corticospinal tracts, they are going to the spinal cord. I also have something called corticonuclear tracts, and the corticonuclears, they are going to stop at the nuclei of the brainstem. And this is what we're going to talk about as we proceed from now on. We already talked about the corticospinal tracts. This is done. Now we are talking about the corticonuclear because we are talking about the cranial nerve nuclei. Cranial nerves, they have their cell bodies in the brainstem. And for the nerve itself to get information, they need upper motor neuron from the higher center. The upper motor neuron, guys, are bilaterally controlling the body except for the genioglossus muscle. It's not bilaterally innervated. And for the lower part of the face, and we're going to talk about that in the facial nerve palsy, not now. Now let's get back to the hypoglossal. What happens is I'm getting the information from the higher center. So if I have a upper motor neuron coming from above, the upper motor neuron will come, it will cross. The upper motor neuron, it will come, it will cross, and then it will give the information to the hypoglossal nuclei in the butterfly level. All right, and then from there, the hypoglossal nerve will go ahead and supply my tongue muscle ipsilaterally, صح? Because all cranial nerve nuclei, they go ipsilateral to the same side of the target. okay? But the upper motor neuron, they cross. Now, if I have an upper motor neuron lesion of the left side here, I don't have any information coming to the right side of my body. Okay, so the right hypoglossal nerve will have a problem. So the right genioglossus muscle is not gonna work. So the left muscle is going to push my tongue where? To the side of the lesioned what? Nerve and muscle, not to the side of the lesioned upper motor neuron. So you have to understand, you should not memorize. If he's asking you about where is the tongue deviating in any hypoglossal nerve injury, you will say the tongue is deviating toward the lesioned muscle and the lesioned final nerve. But if they are asking you where is it deviating in relation to the upper motor neuron, no, it's gonna be to the opposite side. Okay, so this is the opposite side. So this is what I mean by opposite side of the lesion. This is regarding the upper motor neuron. Now what happens to the lower motor neurons? For the lower motor neuron, I have the upper motor neuron. It brought the information to this part at the butterfly level, and this is brought the information to this part of the lower of the butterfly. Okay, now from here I have the hypoglossal neurons, and that is the hypoglossal nerve coming to this. This is hypoglossal nerve coming to that. If I have a problem in the left side of my hypoglossal nerve, I will have a problem in my left genioglossus. So this genioglossus is not working, so the right one is going to push the tongue toward the lesion. So again, if I have a problem, you guys, I have liquor wound, I'm gonna have deviation towards the affected genioglossus muscle and hypoglossal nerve. If it's lower motor neuron, so this is easy, I'm gonna deviate to the same level of my lower motor neuron, like the green color. If I have upper motor neuron lesion, if he is asking me where is the tongue deviating in relation to the stroke or the problem in your brain, it's gonna be the opposite side. And this is what is represented by the blue color. I hope you guys grasp that concept, and let's proceed to the next. What do we have here? Remember that I told you that we have two naughty cranial nerves, the trigeminal. Okay, so trigeminal is going to be for pain, temperature, touch, and pressure from your face, and the half of the medial and inferior vestibular nuclei, because here I was listing to you guys the cranial nerve nuclei related to the medulla, and I had to make it for you in a separate slide, but I'm sure that everyone knows now. So if we have a problem in the medulla, I would expect to see vestibular problem. All right, so I would expect to see vestibular